Today on Diabetes Connections Type 2, have you heard of a diabetologist? This is a newer specialty in the U.S. that may help offset the lack of endocrinologists. Most people with type 2 see a general practitioner, and the diabetology certification helps those doctors learn about the latest in diabetes care. We'll talk about how to find one of these rare experts, why there could be more of them soon, and we'll get advice on how to make the most of your diabetes visit to any doctor. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Hello and welcome to Diabetes Connections Type 2. I am your host, Stacey Sims. For many years, I have hosted a show all about type 1 diabetes, but it's been occurring to me for a while that we need something for the type 2 group as well. Whether you use insulin or not, maybe you have prediabetes, this show will provide information and inspiration for you. My husband lives with type 2 diabetes. My son has type 1. I don't have diabetes, but I have a background in broadcasting. I worked for many years in local radio and TV news, and that is why I started in the podcasting business way back in 2015. We're going to jump into the interview in just a second, but first, I just want to let you know that this month is a big one for diabetes research. Late June is when they hold the American Diabetes Association Scientific Sessions Conference. This is the biggest diabetes conference in the U.S. It's where you get a lot of research updates, product launches, some celebrities. I will be there in person. I would love to know what you want me to cover. I'll be asking that question in Diabetes Connections, the group on Facebook. I'm also going to send an email out to listeners. I will put a link to the Facebook group and to the email list in the show notes. There's also a link to the email sign up over on diabetes-connections.com. Just click on the Type 2 show and look right at the top of the episode's list. The Scientific Sessions Conference is why you're going to be getting a lot of possibly mainstream diabetes news. I've been to this conference before, and boy, the media room is very well attended. And like I said, some celebrities will be there. So chances are good that towards the end of this month, you'll be seeing some diabetes stories on national news, whether it's, the newest CGM or different insurance coverage, or a football player talking about why he likes his insulin pump. So let me know what you want me to cover. There's so much going on there. My guests this week are Dr. Lenny Salzberg and Dr. Jay Shubrook. They're going to introduce themselves and more about their background, but they are both American College of Diabetology representatives. That group just had its second conference this year and certified its first fellows last December. Much more about diabetology, what you may get out of it, and just some general, what to ask your doctor stuff. And, get the most of your limited time with whatever kind of doctor you see right after this. US Med sets the bar high when it comes to diabetes care. US Med excels in customer satisfaction, ranking number 1 in Dexcom customer surveys. And online, they're number 1 in Google and Facebook customer ratings among large national diabetes DMEs. With over 1 million satisfied diabetes customers since 1996, they've perfected the art of delivering better service and better care. From insulin pumps to diabetes testing supplies and the latest CGMs like Freestyle Libre 2 and the Dexcom G6, they've got you covered. Plus, they accept Medicare nationwide and collaborate with over 800 private insurers. US Med, your trusted partner in diabetes care. Your health, satisfaction, and peace of mind are their priority. Visit usmed.com/Stacey. That's usmed.com/STACEY. Dr. Jay Shubrook, Dr. Lenny Salzberg, thank you so much for being here. I appreciate you spending some time with me and my listeners today.
Well, thank you for inviting us, Stacey. I really appreciate it.
It's a pleasure.
Glad to have you here. Let me start by just asking you to give us a little bit idea of your backgrounds. Dr. Salzberg, if you wouldn't mind, I'll start with you. What do you do in diabetes?
Sure. Okay. So I am a family physician, and I do full spectrum family practice, including I delivered babies until last year. So everything. But my entire career, I've been interested in everything, including diabetes. And years ago, we only had one endocrinologist in my city. I live in Fayetteville, North Carolina, and the endocrinologist left. And the nurse practitioner who worked with him had been in practice for 15 to 20 years, and she was very comfortable with all aspects of type 1 diabetes, but she didn't have a supervisor. And she came to me and she said, "Will you be my supervising physician?" And I said to her, "Marilyn, I know you're wonderful, but I don't know enough to be your supervisor. She said, don't worry, I'll teach you. So I became her supervisor, which was great. And I teach in a residency program. So I absorbed her into the residency program. I was the residency director at the time. And so I then inherited a large population of patients with type 1 diabetes. Now, I'd always been interested in type 2 diabetes and type 1 diabetes as well, but I didn't have any patients with type 1 to that point. Anyway, I'd been to all sorts of conferences on diabetes. Years later, I went to a conference at ECU, which is in Eastern North Carolina, and Dr. Tannenberg was leading the conference, and he was one of the founders of diabetes fellowships. And his diabetes fellowship was at ECU. And one of his faculty members was my former program director, so someone I knew well and respected. And I went to this conference and I thought, we should do this in Fayetteville. We have a huge need. We don't have an endocrinologist. There's so many patients with diabetes and there's so much happening. And that was when Byetta was new. So Byetta was brand new. And I was like, wow, this is a new, fantastic, exciting thing. So I met with Dr. Tannenberg and said, how would I start a fellowship? And he said, well, here's my curriculum. This is what you need. This is what you can do. And we had all the components in place. So we started a fellowship. We started a fellowship here in Fayetteville. And then later, Jay Shubrook, who you're all going to meet really soon, contacted me because I was one of the 5 fellowship directors and said, hey, we're all meeting. Let's find out what each others are doing. And we're at the ADA conference. And can we figure out what we have in common, what we do differently? And then Jay really led us to become the American College of Diabetology.
Nice. All right. And so we'll go right over to Jay. Tell us a little bit about your story.
So I also am a family physician and a fellowship-trained diabetologist. We started the fellowship at Ohio University College of Osteopathic Medicine the same year that Robert Tannenberg started the fellowship at ECU. So these both came up organically, essentially for the same reason. I transitioned my practice from family medicine to exclusively diabetes in 2004, mostly because the need was incredibly great. We were in Appalachia, Ohio. There was really very limited access to diabetes-focused care. And so I have been doing nothing but diabetes since then. And that includes clinical practice, research, community outreach, and so on. And, when we saw that the fellowships had lasted, because there's been other diabetologists in the past, we really felt like we needed to standardize these programs so that everyone who graduated would look like a diabetologist, that the public would know what to expect if they were seeing a diabetologist. And so that's when we worked with the ADA, I believe in 2020, to meet, compare programs, develop standards, and we developed a white paper that got published, and then since then have continued to grow programs.
So you've kind of answered the question, but I want to make it really clear. Why diabetology, which is not a word that we hear a lot in everyday conversation, right? You're not talking about an endocrinologist. Jay, let me start with you. Can you just talk about what people should know about that word?
Yeah, I actually think the word is important no matter the background of your clinician. So we know that endocrinology has been the historic landmark home for all things endocrinology, including diabetes and metabolism. And they still are experts in the field. But many people who do endocrinology are less interested in diabetes than they are other endocrinology topics. And so there are diabetologists amongst endocrinologists. And we know that there are not enough people focused on diabetes in the country. And we need to define additional ways that we can provide focus, expertise, and care for people living with diabetes. And certainly anyone in the primary care area could be working as a diabetologist, but there's actually no mechanism to be recognized, no mechanism for patients to be able to find someone that's got expertise in the area. And so the idea of, one, standardizing, at least up to this date, primary care diabetology, and two, making sure that we have a uniform product per se, it now allows the public to seek out someone that might be in their area that wouldn't normally have fallen under endocrinology, but could provide that kind of expert specialty care in diabetes.
Yeah. It's amazing because when you think about how many people with type 2 especially don't see an endocrinologist, don't have access, there's just not enough, as you said, fewer and fewer people going into that specialty. When you phrase it that way, it's incredible to think this wasn't around forever. Dr. Salzberg, I see you laughing at this, but right? I mean, it's amazing to think about how so many, well, let me ask it this way. It's amazing to think that in Fayetteville, right, which went from 1 to none, this is the perfect thing for an area like that.
Exactly. Yeah, so there's such a need. And for many of your listeners who are not in North Carolina is in the obesity and diabetes belt. We have such a large number of people who are diabetic or will be diabetic. And there is so much need. We currently, now in Fayetteville, we do have several endocrinologists, which is very nice. And we actually have a pediatric endocrinologist, which we've had even when we started this, but I was taking care of the adults after they graduated from peds. It is such an overwhelming need. And it's not just in North Carolina. I was talking to some folks from Chicago this week. I was in another conference, and they were telling me, yeah, don't brag about North Carolina. We have as many obese people as you do. I said, well, on the population maps, we're the reddest. And they said, well, that's because there's wealthy communities mixed in with the rest of us, but we have just as much diabetes. So it's crazy. It's everywhere.
So let's talk about your recent conference. I don't want to make any assumptions, but what were some of the big topics or research that you'd like to share?
I can highlight the initial part. So I think one of the things, and one of our goals for all of our conferences is to provide outlets for those people passionate in diabetes to get the latest and the greatest in our kind of spring conference, and then certainly board review for those who want to really make sure they get solid groups of the basics. So this was our kind of latest and greatest conference. And so we had experts from all over the country talking about the prevention of type 1, the prevention of type 2, the interface of hypoglycemia and all the different ways it affects a person's life who has diabetes, trying to help clinicians have better tools to identify and communicate with their patients about hypoglycemia. And then even things like what are some of the new meds out in type 1 and in type 2. And again, I think one thing that's unique about this conference, ACD, is that we really do try to fill the needs of the learners as well. So there is a pretty heavy focus on type 1 diabetes technology and things that maybe some primary care diabetologists would be seeing less of.
That's interesting.
Jay did a fantastic job and hit the high points for all the lectures. We also had a technology workshop. So we had a whole afternoon where we got to interface with the technology. So it was fantastic. So for those who do it every day, it's old hat. But for a lot of the people at the conference, this was new. So it was just a great opportunity.
And when you're talking about technology, you mean pumps, CGMs?
Exactly.
Okay.
Get your hands on it, make sure you know how to operate it, order it, problem solve, things that you would never have time to do in your daily practice.
Well, and that's so important because I talk to so many people who are limited for technology by what their doctor knows, right? Yeah. Sometimes it's very well-meaning doctor, but there's only one sales rep in the area, so they're trained on one brand. And that's the brand they feel comfortable with because they don't want to lead their patients astray, like they can't help the patient with a different type of pump. That stuff is amazingly important day to day. I'm curious, and we can talk about the conference and you guys, whatever you want, but from where you sit, somebody listening to the show, somebody is newer diagnosed. Let's start with type 2, or I guess you can go with any type of diabetes, but I want to mention type 2 here. Someone is diagnosed with type 2. They've seen their general practitioner once. They think they're okay. Like, hey, I have a Libre. I'm taking metformin. Is that all there is? What kind of things can the patient be talking about or bringing to their doctor?
Well, so I would highlight that everybody's skill set is slightly different. And so, there are some family medicine or internal medicine or pediatric clinicians out there that are incredible. I would be happy to have myself or my family members see them for diabetes. I'd like to think that we are a resource for our patients for information and access to early interventions and technology. What is the right thing for that person really depends on that person and that family. When I did family medicine, I'll just speak for myself, it's really hard to do primary care because you have to know a little bit about everything. So my general knowledge is probably lower today than it was 20 years ago. But now I'm a mile deep and an inch wide as opposed to a mile wide and an inch deep. And so when I see someone that it gets referred to us, and they would have to be referred to us to see, at least in my scenario, I want to give them a bunch of choices. And there are, 13 classes of medicines. There's actually ways to achieve diabetes remission in type 2 now. And so there is lots and lots of choices. And I hope that diabetology will not only serve those individuals through the diabetologists, but actually raise the water for everyone. So I actually work in an FQHC next to a bunch of other primary care clinicians. And 4 or 5 times a day, I'm getting a question about, could I do this? Would this be appropriate? And for me, that's just as important as that patient interface, because I want all clinicians to be comfortable working with people with diabetes and giving them the best choices. So I think that was a partial answer, right?
It's a great answer. But before we go any further, what does FQHC mean?
Oh, Federally Qualified Health Center. This is the safety net clinics across the country.
Excellent. Thanks for clarifying that. One of the questions I get is like, what questions do I ask my doctor? I don't even know what to ask. Over the years, my family has tried a lot of things, and we found a great tool to keep your insulin at the exact right temperature. It's called a VIVI Cap, and even in the extreme heat or cold, this does the job. It basically goes right over your insulin pen. It acts as a cap. You actually take the regular cap off the pen and slide on the VIVI Cap. It lasts for years, it fits all pens, and it's super easy to use. If you live in a place with extreme temperatures like we do, in the summertime around here, Benny can be outdoors at camp. He was a lifeguard this past summer. It can get over 100 degrees, and you don't want to put your insulin at risk. It's FSA and HSA eligible, as well as TSA approved, and they'll give you a 2-year warranty. Learn more. I've got a link in the show notes. You always get a discount when you use it. You'll find the same link at diabetes-connections.com. Look for the TempraMed VIVI Cap logo.
I think Jay's answer was fantastic, especially the part about family docs have to know a little bit about everything. Same thing with general internists. And frequently the depth of knowledge isn't as deep. It's definitely not on everything because you can't be an expert on everything. But one of the things that a good family doctor should be able to do is be able to engage the patient, hear the patient, and know what the patient's story is. So that's the most important thing. And Jay is right. You need experts to refer to because as a family doc, I do have expertise in diabetes because I teach and lead the fellowship. But if I didn't, I might not know all the options. And I might be comfortable with 1 or 2 pumps, but not all the pumps. And you need to know everything in order to give the best care. But some of the things the patients need to be able to bring to us is how do they interface with diabetes? How does diabetes affect their life? Is it affecting their day-to-day life? Do they have distress due to the diabetes? So diabetes distress is a big thing, but not every physician knows to ask about it. Do they have questions about what to eat, when to eat, how to eat? These are all things we can do. We can also, as Jay said, we can use our resources and refer to a diabetologist. We can refer to a person who does diabetes education. We can refer to a nutritionist. There's a lot of people we can refer to, but we need to know what you need as a patient to know. The other thing, and this is a huge thing, and you mentioned metformin earlier, I have had patients in the past, metformin was the first line agent for diabetes. I've had patients who've been on metformin, and when I ask in follow-up, are you still having diarrhea? Because they're like, still? I'm like, yeah, we expect it. And they're like, yeah, I just thought that was normal. I thought it was due to something else. So you need to let us know things that are not normal, even if you think they're normal, even if you think, well, everyone has that. And you don't have to suffer. We have other options that don't cause all the side effects.
Yeah. No, that's a great one. I think so many of us, diabetes or not, sometimes we think this isn't a question. This is just the way it is.
Yes.
This exactly. Is just how I'm always tired because I'm a mom. Exactly. I'm losing weight because isn't that a good thing? We don't think to ask.
Exactly.
Yeah.
I saw someone yesterday as a patient that was just diagnosed with diabetes the day before. And so it was great that I could see them. And so your question is, what questions should they ask? And this person was like young, but totally on it. She said, I want to know what kind of diabetes I have. I want to know what sort of things are going to get me in trouble. And what should I expect with this problem? Because I'm pretty young. And I thought, wow, this person has got it together. And these are really important questions. And I'm going to have some answers today. And some answers we're going to have to develop over time as we see how things go. But I think too often in all types of diabetes, and there's like more than 20 types of diabetes. So that question about what type is important is, what does it mean in my life? What were causative factors and are they actionable? And then how do I get ahead of this if you want to get ahead of it? So that person yesterday, I talked to the patient about diabetes remission. I said, there are ways, if we do very aggressive treatment, you have a high likelihood of not needing medicine long-term, but it is intense work up front. And that person actually said, this is all new to me. Can we just do step 1 first?
Right.
Of course, this is your journey. So we just did step 1. But I think it's important for patients to have that buy-in, have that ownership as much as they can. You're adjusting to a new chronic condition. And then it's our job to be that resource, information, tools, so that they can, at whatever step they are in that condition, they can best engage.
How much have medications like Ozempic and Mounjaro and Saxenda, all these injectables, how much has it changed not only what patients are asking you about, but how you practice?
So, yeah, that's a great question. So it used to be metformin was first line for everybody, and that's no longer the case. And the reason is the medications, like you mentioned, they're GLP agonists. and GLP, GIP agonists, they change outcomes. So it not only helps control your sugar, but it also prevents heart attacks, prevents progression of kidney disease. So those have become first line for a lot of patients, and they come with their own issues. Like people don't want to give injections. People can't afford it, and their insurance doesn't cover it. And you can't get your Ozempic until you fail Trulicity first, or whatever the insurance says. So there's a lot of other issues. And then some people they don't want to do an injection, so they will do anything but. So they say, can I have the pill form of Ozempic? And we say, okay, that's an option.
Is there a pill form of Ozempic already?
There is.
The semaglutide orally is available as a once-a-day tablet versus semaglutide injectable weekly.
How does it work? I mean, does it work as well?
It has similar reductions in A1C. I think the weight loss is a little bit less, and it currently doesn't have outcomes yet, but they're studying.
Yeah, I was going to say it's pretty early on.
Yeah.
It's pretty early on.
And I think that what Lenny said is really important. I think that the new classes, GLP-1s, the twin incretin GLP-1, GIP, SGLT2s, they have transformed type 2 diabetes care in that now we can actually not only reduce glucose, but we can reduce complications. But I would say that they're just a tool.
Yeah.
This is still a chronic condition. It still has to have substantial, we know the great majority of work in all forms of diabetes is on the back of the patient with diabetes. And so we still need to equip them with all those self-care tools while they're using these other tools to help reduce some complications. So I think in some respects it's transformative, and in others we're still doing the same work. And I think it's important that patients know there's no simple cure. It's work. It's a lot of work, and it's a lifetime of work.
And Stacey, going back to the original question, what should patients ask? Another thing they need to know is, how does this fit in with my other chronic conditions? So a lot of people with diabetes also have high blood pressure. A lot of people with diabetes also have hyperlipidemia or high cholesterol. So, or they might have hypothyroidism, or they might have COPD. There's other conditions, and people aren't their disease. People are people, and they have diabetes. So where does this fit into everything else? And then there's all the issues about, what can I afford? What can I do? How much exercise can I do? How can I change my diet? How much do I want to change my diet? I've had patients over the years who have told me, yes, I understand. Yes, I understand. They know all the facts, but they don't want to change a thing. And
change is hard. I mean,
yeah,
if dieting was easy, if diet and exercise were so easy, we'd all be size 2. I say that all the time. It's tough. It's tough stuff.
Yeah, I might just say one thing. I think that one area where I think diabetology from any training background is important is there's a number of transitions in care that are really tough. And I think we were just talking a little bit about your family, and the young adult with type 1 diabetes is a big gap in care. Many kids with type 1 get very family-focused care in pediatric endocrine clinics, and then basically they're plopped out into the world of adult care. And not necessarily, the transition can be quite hard. And for me, I love that patient population, because as a former family medicine focused physician, I was doing all those things in family medicine that you would do. And then I just keep seeing them when they're adults, because in family medicine, you can see adults and kids. So some of my favorite interactions are with young people as they transition in life and help them navigate that transition with a chronic condition like type 1. And I think that, that's a really big need. It's an area that we need to focus on. I think also now that we have some screening tools to help identify people at risk for type 1, in adult endocrinology clinics, we don't necessarily see family members of people with type 1. But those that do primary care diabetology, especially if they're still doing primary care, see the family and actually can talk to the person with the condition and their family members in a coherent way to say, this is something that you can be screened for if you want to know. And so I think there's really some unique places where I hope diabetology fills in gaps in care.
That's great. Yeah, I agree with all of that, especially the transition. We're very lucky. My son is able to stay with his pediatric endo, but not everybody can, and it won't be for that much longer.
One other thing I'd like to add about the American College of Diabetology, we started out as 5 fellowships in the country. There's one in Fayetteville, North Carolina, one in Greenville, North Carolina, one in Colorado, in Denver, one in Northern California in Toro, and one in Ohio. So those are the 5. But since we've formed, we've actually helped start 5 new diabetes fellowships in the country. So there's one in South Carolina in the Charleston area, one in Ithaca, New York, so upstate New York, one in West Virginia, one in Houston, and one in Providence, Rhode Island. And part of that happened because we got support from the Helmsley Foundation, who gave us grant money to help give grants to help start these new fellowships. So I have to really thank the Helmsley Foundation for that. But we're growing the field, and we are going to give out 4 more grants to new fellowships over this year and next year. So our goal is 9 new fellowships to start in these 3 years.
That's great. Well, Jay, then let me ask you this. What's the big dream here, right? No holds barred. It's so new and people are still learning about you guys. What's the goal?
For me, the goal would be to have enough diabetologists across the country to meet the need. So we have a lot of people who need us, and there's not enough of us to go around. That's my dream.
Yeah.
Yeah. And I would agree that we know that the rates of all types of diabetes are increasing. The number of clinicians trained in diabetes is not increasing. So we need to really focus on that. So I would say that all people with diabetes get the care they need. And then I would also say that the American College of Diabetology becomes a medical home for clinicians of all types that are focused on diabetes, regardless of their primary background. So it could be cardiologists, it could be OBs, it could be endocrinologists, it could be family physicians, it could be NPs or PAs. We want the public to know where they can go to get care focused on their patient with diabetes.
Before we started taping, Dr. Salzberg, you said you had a couple of questions for me. I'm a little nervous, but I think they're probably just about Benny. So
no, thank you. Thank you for letting me. So I've listened to some of your podcasts, and I really think they're really well done. I really appreciate them.
Oh, thank you.
And I am impressed that Benny did so well in college, in his first year of college, and he's come home. And one of my questions was, so Jay talked about transitions. And I, as a family doc, I see that people with chronic diseases, when they transition from pediatricians to internists, or if they stay with me, a family doc, there are a lot of times where the ball gets dropped, where things get lost. And it's not necessarily on the patient side, it's not necessarily on the physician side. It's just that 19-year-olds, 20-year-olds they still have their brain forming. They're not fully functional adults until they're 26, probably. So I was wondering, how's your son done with his transition? And has he transitioned from I knew he was going to an endocrinologist. Has he transitioned from a pediatric to an adult endocrinologist? And so how's he doing?
Okay. Well, he's going to come on the podcast in the next couple of weeks, and we're going to do a debrief. I will tell you in advance, I don't know if you guys know, my book series is called The World's Worst Diabetes Mom. And I say that because I do not believe in perfection, and I believe in learning from mistakes. And my kind of parenting, and we all parent differently, was not well suited to super controlling a child with type 1 diabetes. It just was not. I wanted my kids to be as independent as I was and do dumb things and be okay. And my luck was that I heard from a lot of adults with type 1 very early on in my journey who said he's going to mess it up and that's okay. So when I say Benny's doing well, I will tell you his A1C was a lot higher this year than I would have liked. And I've been very honest that I don't share his numbers. They're not my numbers to tell. So I haven't shared his numbers since I think he was in like 4th grade. I don't like to do that. I wasn't happy about that, but our endocrinologist told me, back off, he's fine, he's safe, leave him alone, which is really hard. So in terms of dropping the ball or things like that, as I mentioned, he was able to continue seeing his pediatric endocrinologist through college, which I'm really thankful for because we've had the same endo since Benny was 23 months when he was diagnosed. Thankfully, that's wonderful. He's fabulous, and he really gets our style of management. To give you a little clue of my son's personality, a couple of years ago when Medtronic came out with their 7-day infusion set, I mentioned this to him. We use a tandem. He uses the tandem T-Slim. And I said, we could switch to this, it's 7 days. And he said, Mom, any infusion set is 7 days if you just believe. Now, obviously, he's not stretching it that long, or he'd have infections, he'd have scarring, he'd have issues, but I know he's done it a couple of times. Let's be honest. Okay. So he does see a family practitioner as his general practitioner, right? So when he was a teenager, he was like, get me out of the pediatrician for my regular stuff. So that I think is very helpful because he can see this guy as he's an adult. But has the ball been dropped? Absolutely. We had some weird insurance snafus, so I had to overnight him some insulin at one point. But he did tell me before it was an emergency, so that was great. We had a Dexcom snafu. Again, we have really bad insurance because we buy it on the marketplace. So I had problems transferring it to a local pharmacy. He's out of state. So he went without a Dexcom for 3 days. And the transmitter was sitting in the mailroom, and he just didn't go get it. And I'm home going, what are you doing? He's like, I'm fine, Mom. So high level, he's fine.
Well adapted and rolling with the punches, like human life.
We like to say resilient, right?
Yeah, that's awesome. That's
So
awesome.
that's a long answer to your question. I worry all the time. I want to make sure he's okay, but I do think he's okay enough. And I think part of that is he's a good kid. He's responsible. We've taught him to respect diabetes and not fear it. Part of it is he has incredible access to technology. We're so fortunate to be able to afford it. I say we have bad insurance. It's good enough that I can afford an insulin pump, a continuous glucose monitor that talks. I mean, when he was 2, we never thought. This is amazing. So it keeps him safe enough. So long answer to your question, but I could talk all day about it.
I have 3 children, 22 to 29, and I've seen the transition, and they do become adults and they become independent.
Please.
But there's a process. There's a process to it.
He's home for the summer, which I'm really thrilled about. But we did have a conversation just last night. He just got home. And I said to him, I need some help because now that you're in my house, it's really hard for me to watch you eat dinner and not say, did you bolus, right? Where's your pump? Did you bolus? What are you doing?
Yeah.
So we talked it out last night, what our routine's going to be. Our routine is going to be me leaving him alone. It's never a dull moment around here.
Yeah. No, that's fantastic. Thank you for sharing.
Thank you for asking. It's so funny to share with you guys. It's like, I don't know. Some days I'll be honest with you. And I think many people with diabetes feel this way. Some days I feel like I'm doing everything wrong for him, right? Even now, even 17 years later, when I know he's great. And some days I feel like, wow, what a good kid. He's doing everything right. It's a hard condition. It just doesn't let up. And, you got to keep moving forward.
Yeah. It's like all other things in life. Sounds like you're all well adjusted. Very
I love it. Well, thank you so much for asking about me and my family. I didn't mean to monologue there, but I really appreciate your time. Keep us posted. You're welcome back anytime, and I hope to talk to you again soon.
Great. Thank you so much.
Much more information over at diabetes-connections.com. I know most people will listen in an app. Just for the record, most people listen to this show in Apple Podcasts. But wherever you listen, there should be a way to get to the show notes. If you can't, if some apps have the links show up very strangely, you can always head over to diabetes-connections.com. You can use the search box in the upper right to find our past episodes. But you can also just go to every episode's individual homepage to find out more and get the links that I talked about. And I'd really love it if you could sign up for the email that I mentioned at the top of the show. We send out a monthly newsletter. I don't spam you or bother you too much. But that's also how I send out paid study opportunities. And it's where we'll be asking about what you want me to cover at ADA. All right, that's the show. Thanks to my editor, John Buchanan at Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.